powers, product breakthrough achieved on the endoscope imaging system, and planning for future intelligent surgical system have indicated that it owns complete solutions in both traditional open operation field and minimally invasive and precise operation field. Among them, Xishan's surgical equipment products have covered many surgical fields, including neurosurgery, spine surgery, joint surgery, otolaryngology, ophthalmology, and maxillofacial plastic. And have provided safer, more accurate, and more efficient surgical devices for clinical applications.
Dear guests, the seminars will begin shortly. Please be seated and kindly turn off or set your handphone to silent mode throughout the entire session. Your cooperation is highly appreciated. Thank you. Assalamualaikum warahmatullahi wabarakatuh. A very good morning and warm welcome to the Honorable Professor Dr. Fazli Jalal, PhD, as a Rector of Yarsi University, the Honorable Professor Dr. Pratiwi Pujilestari, PhD, as a Dean of Yarsi University, Dr. Asri Afianti as a Coordinator of this event, all of our speakers for today's special occasion, and also Mrs. Carmina, a Founder and Executive Director of Neurosurgery Outreach Foundation. And all honorable guests and participants for today's special seminars, a comprehensive overview of SPINA Bifida. Good morning, everyone. My name is Dr. Amalia Ramadhani, and it is my delight to be the Master of Ceremonies for today's special agenda. We hope that you'll gain more knowledge transfer and fruitful discussion throughout this entire session. Before we begin our agenda for this morning, I invited all the guests to stand up and sing Indonesia National Anthem, Indonesia Raya. All the guests, please stand up. the guests please be seated. Next, I would like to call upon Professor Dr. Fazli Jalal, PhD, as a rector of ERC University, to address a few words before commencing on today's seminar. Please welcome Professor Dr. Fazli Jalal, PhD, for the warm opening speech.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to all of you. Our distinguished guest, Professor Philip R. Aldana, a renowned neurologist and also board certified pediatric neurosurgeon from US. Let's give a big applause to him. And also Madam Carmina Aldana, founder and executive director for the foundation, helping a lot of children in this regard. And our distinguished guest, also Dr. Ailem Okal, also from US. Let's give a big applause to her. Yeah. And Prof. Partiwi, Dean of School of Medicine, Vice Rector for Academic Affairs, Vice Rector for Research, ladies and gentlemen. It is an honor for us to have two distinguished and world-renowned neurologists, and also working a lot with the different kind of the disease related to neurology, and especially for children, give us wide perspective on how at ERC University we can develop and link from cellular into community. We have hospital, we have community outreach, we have a very advanced genetic research center. And for that reason, I think the guidelines and also the view and vision to the future from both of our speakers and also Dr. Asi from our university can give us insight. What could we do for the betterment of our children, especially in many kind of neurological problem that now can be detected as early as possible, and then we can have a better intervention starting from family and ecosystem surrounding the children, and also from the community health up to the top referral center. So thank you, Professor Aldana and Dr. Okal, for your precious time with us. We are really honored and appreciate your willingness to come to Jakarta and Indonesia, and with the wish that we can continue this cooperation further. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Professor Fazli, for the warm opening speech. And next, a joint prayer will be held, led by Ustadz Fazlur Rahman. Ustadz Fazlur Rahman, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Bapak Ibu yang dimuliakan Allah, seluruh peserta seminar, insyaallah sebelum kita mulai, izinkan saya memimpin doa agar Allah Subhanahu wa taala memberikan keberkahan pada hari ini dalam seminar ilmu yang sangat bermanfaat, dan mudah-mudahan ilmu ini insyaallah bisa menjadi amal kebaikan bagi kita semua. Sab'al masani al-Fatihah. A'udzubillahi minasyaitonir rajim. Bismillahirrahmanirrahim. Alhamdulillah. Iyyaka na'budu wa iyyaka nasta'in. Shiratal ladzina an'amta 'alaihim ghairil maghdubi 'alaihim. Amin. Allahumma ighfir lil muslimina wal muslimat wal mu'minina wal mu'minat al ahya'i minhum wal amwat innaka sami'un qaribun mujibud da'wati wa ya qadiyal hajat. Allahumma inna nas'aluka ilman nafi'an wa rizqan tayyiban wa amalan mutaqabbalah. Ya Allah, ya Tuhan kami meminta kepadamu ilmu yang bermanfaat, ya Allah, amal-amal yang Engkau terima, ya Allah, rezeki yang Engkau berkahi, ya Allah. Allahumma inna nas'aluka ilman la yunsah. Ya Allah, kami minta kepadamu ilmu yang tidak kami lupakan ya Allah, ilmu yang tertanam di dalam hati kami ya Allah, sehingga berbentuk amal soleh ya Allah. Rabbana taqabbal minna innaka antas samiul alim wa tub alaina innaka antat tawwabur rahim. Rabbana arinal haqqa haqqa warzuqna ittiba'ah wa arinal batila batila warzuqna jatinabah. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzaban nar. Da'wahum fiha subhanakallahumma wa tahiyyatuhum fiha salam wa akhiru da'wahum anil hamdulillahi rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Ustad. For the next session, we will have a photo session. All is open. Please remain seated, and the photographer will take the picture from the front. For today's seminars, we will separate it into two sessions, and we're going to start from the first session first. There are 3 speakers for the first session. The first one will be Professor Dr. Philip Aldana from USA, and the second speaker is Dr. Elim Okal, also from USA, and the last speaker will be Professor Dr. Sultana Faradz. The session will be led by Mr. Ahmad Rusdan Handoyo Utomo. Please let me introduce our moderator first from his curriculum vitae. So this is a curriculum vitae for our first moderator, Mr. Ahmad Rusdan Handoyo Utomo. For his education background, postdoctoral fellowship, Harvard Medical School, PhD Molecular Medicine, University of Texas, BS Chemistry magna cum laude, Angelo State University, San Angelo, Texas, USA. And this is also his achievements. Right now, he's a lecturer at Yarsi University, Magister and Doctor of Biomedic Program. I kindly invite the moderator to go to the front and start the session. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very warm welcome to everybody, especially to our guests from America. I used to be 17 years in America, but I guess I lost my southern twang. So it's my pleasure to introduce our speakers. It's going to be an interesting overview. The first speaker would be Professor Philip Aldana. He got his medical training actually in two countries, in the Philippines, also in St. Louis University Medical College in Missouri. And he is now actually a chief clinical pediatric surgery in University of Florida, Jacksonville. Good football team. Okay, so let me put the ground rules. We're going to have this, the first session, we're going to learn from Prof. Aldana about the SPINA Bifida. The total amount of time is 45 minutes, but I guess Prof. Aldana is not going to use the whole time. I would suggest maybe if you could, maybe around say 30 minutes or so, so we have enough time for Q&A, if it's okay. And then after that, we're going to go for the next session for another topic, again on SPINA Bifida. So without further ado, Prof. Aldana, please come to the stage and share your presentation. Thank you.
good morning. While he's getting that started, I want to express my heartfelt gratitude for being here today. My colleagues are here from the U.S. In behalf of the Neurosurgery Outreach Foundation, but you can think of us better as just friends of Dr. Astri. She's the reason why we are here. It's not working. Yeah. Okay, we can just get. You can just use the presentation that I have up there. Yeah. So Dr. Professor Jalal and the rest of the faculty of YRC University and friends, thank you very much for being with us today and being a part of this this comprehensive review of spina bifida. So I'm going to start off by talking about the whole spectrum of spina bifida. And I might speak a little fast so I can reach the 30-minute mark. So as I was introduced by Dr. Otumo, I'm the chief of pediatric neurosurgery at the Wolfson Children's Hospital and a professor of neurosurgery at the University of Florida in Jacksonville and Mayo Clinic, Florida, and also head the Neurosurgery Outreach Foundation. So this is our region in Florida. By that. The trapezoid is where we draw patients from. About 1 million children in that region come to our hospital. We're the only children's hospital for that region. And we treat all types of pediatric neurosurgery disease. We also serve as the training program for the University of, for the Mayo Clinic. And we are consistently ranked as one of the top children's hospitals for neurosciences. I'm also the founder of the Neurosurgery Outreach Foundation along with my wife Carmina, and we are from the Philippines, and we started this in 2010 where we advance neurosurgical care in underserved communities. Right now we have partner sites in the Philippines, Mongolia, and Ethiopia, and we educate local neurosurgeons on neurosurgical techniques. In addition, we also give out educational awards to neurosurgeons in training, and the most number of our awards actually go to neurosurgeons from Indonesia. And so the neurosurgeon in point here is Dr. Astri, who was one of our first awardees in 2014 in Singapore, and in 2019, she came to visit us in Jacksonville for a traveling fellowship from July to August 2019. And there she is with my wife, August 25, 2019, in St. Augustine, Florida. However, 3 days later, this is what happened in Jacksonville. There was a hurricane, Hurricane Dorian, that almost had a direct hit in Jacksonville. So we were worried because we had to take care of Astri, so she had to evacuate her apartment and stay in the hospital. So this was the room that they were staying in on that night of the hurricane. But thankfully, everything turned out fine, and she also made friends from that are still friends with her today. So we're very happy to be here with Astri and to participate. So let's talk about spina bifida. The condition was described very early on by Hippocrates and Galen, and probably in the 1500s was the first described case of cervical spina bifida. In the 1600s, Tulp described 6 cases, and he was the person that gave the term spina bifida. He had attempted to ligate the sac in one patient, but that patient died of an infection. So here you can see the pointers. Oh. Anyway, you can see here the large head there for the hydrocephalus, and then down there at the bottom is a spina bifida. So spina bifida is part of the spectrum of disorders called neural tube defects or spinal dystrophism. And so spinal dystrophism refers to all forms of spina bifida. Spina bifida is the most common cause of congenital disability worldwide. So most common cause of disability, congenital. There are 2 forms generally. The one that's open, where there's an open lesion, or spina bifida cystica, which we'll see later, myelomeningocele or myelocystocele. And there's also spina bifida occulta, where it's covered by skin. So how does this form? So the embryo starts off with 3 layers. The ectoderm, which is the outer layer, forms a thickening called the neural plate, which is there on the top, and the neural plate then forms a groove, which is here on the right. That one there. Do you have another pointer? And the groove then forms a tube called the neural tube, and that process is called primary neurulation. So here at the bottom is an electromyograph of the groove, and then forming a tube together. So when primary neurulation occurs, it starts on the post-ovulatory day 16, and by the 3rd week of gestation, it's already finished, and that forms most of the back of the neural tube, and there are 2 openings that remain: the anterior neuropore and the posterior neuropore. If the neural tube fails to close, then there's what we call a neural tube defect. And what does that look like? I will show you. The bottom of the spinal cord closes by this process called secondary neurulation. So it's a closure of the posterior neuropore. And how that forms is there is a mass of cells at the very bottom of the neural tube, and all those cells come together, and some become the genitourinary tract, and some become the GI system, and it then becomes a tube all the way down. You see this the third illustration here, and then that tube goes away to form the phylum terminale. Okay, thank you. Yeah, so this bottom here is the phylum terminale. So the conus medullaris is formed, phylum terminale, and the lower sacral roots, and if there's a problem with secondary neurulation, then you also have associated problems with the urinary system, like bladder extrophy and sacral agenesis. And this is just another picture. If the anterior neuropore does not form, then you have anencephaly. This is a closure point in the middle. If this does not form, you can have craniorachis. And if the posterior neuropore does not form properly, then you have spina bifida. So this is a picture of that if the secondary neurulation does not complete its course, you can have fat in the phylum terminalis. So this is a surgical micrograph of a fatty phylum. And that's the problem with the retrogressive dedifferentiation if they have a problem. Okay, so after the neural tube forms, the next process is called disjunction. And what happens there is the neuroectoderm separates from the cutaneous ectoderm. So this is the cutaneous ectoderm, this is the neuroectoderm, and they're supposed to separate. So these two ends come together to form a complete tube, and then it separates to form the neural tube and the ectoderm. And if you have disorders of this, you can have cutaneous elements into the central nervous system. So what does that look like? So in a defect called premature disjunction, the cutaneous ectoderm, which is here, separates prematurely from the neuroepithelium before the tube is closed. So you still have an open neural tube, and what happens is the elements of the skin then invade the neural tube. And so that's how you get fat into the spinal cord. So you get a lipomyelomeningocele, even though the spine is still intact. So here is an MRI sagittal showing the fat in the skin and the defect in the spinal canal and the fat going inside the spinal canal. So that's a spinal lipoma. So let's see if this works. So, oops. Yeah. So can you move the video further? Yep. Faster a bit. Yep. Stop there. Okay. Keep going. This is just the history of the baby. Yeah. Keep going. Yep. Maybe 30 seconds. Go 30 seconds. Okay. So stop. There's an MRI showing the fat over the spinal cord. And so here's the fat, and then there's what we call a syrinx. Okay, can you move forward 30 seconds? Yep, keep going. Okay. Let's see where we're at. Right, so here we drilled out the lamina of the spinal canal, and so this is the dura. And here we do an intraoperative ultrasound. Stop there. There you can see the fat. This is the end of the spinal cord, and those are the nerve roots. Okay, move forward 30 seconds, please. Yeah, keep going. So here we're opening the dura. Keep going. Yeah. Okay, stop there. So yeah, so this is the fat here in the spinal canal. There's a spinal cord, and what we do is we separate the lipoma from the spinal cord dorsally, and here we're just separating, we're just dissecting basically the fat of the spinal cord there. Yeah, so we're just removing the fat off the spinal cord there. Okay, I think that's enough. Let's go to the next slide, please. Okay, so there's another problem with disjunction called incomplete disjunction. So what happens here is the separation does not complete itself, and so the the cutaneous ectoderm is still connected to the neural tube. And so here at the end, you see this is the skin tissue, and it's all the way down into the spinal canal. So there's that persistent tract. That results in a dermal sinus tract with dermoid tumors or limited dorsal myeloschisis. So I'll show you, yeah. So the problem with the dermal sinus tract is it can be an open communication from the spinal cord to the skin and puts the child at risk for meningitis or abscess. There are tumors inside made of skin cells. They're benign tumors, and the treatment is resection. Okay, so this is a child that was born with a port wine stain. So this is the gluteal cleft. So the legs are down here, and you see there's a tiny dimple there. And the alert pediatrician said, "Oh, this is not normal," and obtained a consultation with neurosurgery, and we obtained an MRI that showed the dermal sinus tract. So here we are at surgery. This is the opening in the skin that we excised, and it's connected to this tract that's going down to the spinal canal, and this is the dermoid tumor here, made of basically skin cells, and you can see the tract attaching nicely to that. So we resected that, and that was fine. This is a baby who was born with a little tail. Again, also, this is the bottom of the butt, and the legs are here. And this is a limited dorsal myeloschisis. And what that is again, there's a little tract here that goes, you can see it here, go down and go into the spinal canal. It can cause a tethered spinal cord. So there's that tract again. Here's the dura, and you can follow the tract inside here, and it's attached to a nerve root. So we just had to excise that. Let me just spend a few minutes on the different skin markers for spina bifida. As a rule, if you see an abnormality that is more than 2.5 centimeters away from the anus and is greater than 5 millimeters in size, if there's any drainage, has any other associated abnormalities, then this is at high risk for having spina bifida, occult spina bifida. So this one here, this is a normal dimple here. You see there's a tiny thing here that's inside the gluteal cleft. That's just your normal sacrococcygeal dimple or pit. As opposed to this one here, you can see there is a dimple above the gluteal cleft. That's one at high risk for spina bifida, occult spina bifida. So if you see that in a baby, needs further workup. Typically either a ultrasound if they're young, ultrasound of the spine, or an MRI of the spine. Here's another cutaneous abnormality. So this is the back of a patient. Looks like they have scalp hair. So hair can be another marker. And this is a marker for the split cord malformation. The split cord malformation is a bit complicated, but if you remember your genetics, your embryology, the neural canal and the notochord, which is the notochord, is here. They are split by a persistent accessory canal, and it communicates to the yolk sac and the amnion. And so what happens is the neural tube is split, but the ectoderm is closed. And I'll show you. And so you can actually have two halves of the spinal cord that are separated either by a big piece of bone called a bony septum. This is diastematomyelia, or split cord malformation type 1, or a fibroseptum, which is a split cord malformation type 2. So this girl was actually adopted from China, and her parents brought her in because she had trouble walking. And so here's the CT scan showing the bony septum that's going through the spinal canal, and she has 2 separate spinal cords. Here's the MRI showing the 2 separate spinal cords. Here's one, and there's the other. And this can cause a dysfunction of the lower extremities. And here's just the abnormality here. There's a fusion mass of her vertebral bodies that did not form properly, and this is where the split cord malformation is. So using this as a guide, this is the bony spinous process that's fused. We took her to surgery, and this is that spinous process there, and this is the covering of the spinal cord, the lamina, and so we did a laminectomy. We removed the bone, and here's one spinal cord, and there's the other spinal cord, and this is all the bone in between the 2 spinal cords. And so we resected the bone with a drill, took that out, and then there's this is the dura of one spinal cord, that's the dura of the other spinal cord. So not only the bone can cause a tethering of the spinal cord, but the dura itself, so we had to excise the dura as well. So we opened the dura, and here's the spinal cord on one side, spinal cord on the other side, and then we're resecting the dura in the middle. So the patient did fine, and we were able to complete that. So in summary, if you have a defect in primary neurulation, you can get myelomeningocele or encephalocele. If you have a defect in secondary neurulation, you can get fatty phylum. If you have incomplete disjunction, you can get dermal sinus tracts or dermoids or epidermoid tumors. And if you have premature disjunction, you can get lipomas or lipomyelomeningocele. And if you have a disorder of gastrulation, you can get a persistent neuroenteric canal, where you get a split cord malformation. So let's talk about myelomeningocele. How many minutes do I have left, Dr. Otumo? 5 minutes. Okay. All right. I will talk faster. Right. So myelomeningocele, we talked about it, the defect in primary neurulation. There's a unified theory where here is a fetal MRI of a patient, a baby with fetus with spina bifida, and the fluid down here you can see, and what happens is when there's an opening of the fluid, then the fluid can drain out, and when it drains out, the brain slides down. It basically is not buoyant anymore. What happens then is you get a sliding back down of the brain to form the Chiari malformation, which I'll see. So for patients with open myelomeningocele, they not only have problems in the spine, but they also have problems in the brain, where they can have polymicrogyria, corpus callosum dysgenesis, hydrocephalus, posterior fossa, descent of the cerebellum, lots of different problems with the brain. These patients have hydrocephalus about 75 to 80% of the time. How were these treated? In, I think, the late 1800s, there was the first description of a layered closure of the back. In 1950s, Spitz, who was an engineer, developed a valve for the shunt, and so they were able to make shunts for hydrocephalus. Okay, so this is how we close a myelomeningocele. Here is the skin, and this is the neural tissue called the placode. And Can you fast forward, please? So this is, can you play the, yeah. So we're dissecting the skin away from the placode and doing some more of it. Yeah, move 30 seconds, please. Yep. And so we just come around the skin altogether. Yep. And now this is separated from the skin. So this is all the neural tissue separated from the skin. Okay. Move forward 30 seconds. So then we harvest the dura around the spinal cord. Okay, you can stop there and hit and play. Yeah. So now what we're doing is the open neural tube we're going to close with sutures. You know, we put sutures on one end, one edge of the spinal cord, and bring it together. So there's one. Okay, can you fast forward, please? I'm sewing too slow. There, okay. Yeah. So after that, after we bring the edges together, then we're going to close the dura. So we do the same thing where we close it with sutures again. There, those two edges we'll bring together with the suture. You can fast forward. Yep. Okay. And then, you know, and then we end up closing it. All right. So because the spinal cord doesn't form properly, then the rest of the tissues get denervation injuries. For the bladder, you get a neurogenic bladder, 90%. For the extremities, the muscles don't form properly, so they get extremity deformities like club foot. They also have learning disabilities, they get ulcers, and they can have growth hormone deficits and precocious puberty. And then as they grow older, because they have hydrocephalus, they can get a shunt malfunction, they can get a tethered spinal cord, they can have trouble with their brainstem, and they can also have seizures. And this continues in adulthood. Because they are disabled, they are obese, they can get hypertension, renal disease, sexual dysfunction, and you know, it's very hard for them to work or earn money. So they have socioeconomic problems. And so their complex medical problems require a multidisciplinary approach. This is a document from the American Academy of Pediatrics advocating for a medical home for the patients with spina bifida, where there's a comprehensive multi-specialty program. In our center, we have a spinal defects clinic where we have all of these providers meet with the patient on the same afternoon: neurosurgery, pediatrics, urology, orthopedics, GI, rehab, physical therapy, social work. All of them converge on the patient to try and give them the best care. Okay. And so, yeah, we reported the patient satisfaction from this clinic, and 62% of them were better informed, and 52% felt that their medical care was better coordinated. And a quarter didn't have to go travel elsewhere for care. Okay, so in the last few minutes, let's just talk about how what's happening in the arena of in utero repair for myelomeningocele, which was started off by this landmark paper in 2011, this randomized controlled trial comparing in utero repair versus ex utero repair. And again, the thinking was, if you close this defect, then the problems in the patient may not be as severe. And so that's a diagram how they do it. You know, they open the uterus, and they close basically the placode, which is very similar to how we close it outside of the uterus. But it's a very, very complicated endeavor involving a lot of services, which I'll show you. So the results of this trial showed that this is an important one. In 1 year, 40% of them had hydrocephalus requiring shunts versus 82%, so more than half reduction of hydrocephalus. And brainstem dysfunction, motor function was improved. So really benefiting the baby. A lot of benefits to the baby. To the mother, not so much, because they had placental abruption, chorioamniotic membrane separation, spontaneous membrane rupture, all of that. So not as good for the mother. Also, the problem was there was more preterm births. So the mean gestational age of the fetal surgery patients were 34 weeks, and of course the postnatal was termed 37 weeks. Okay. So long-term results, what do those look like? So in the same population, now that they're school-age kids, same benefits for Arnold Chiari malformation. They have less VP shunts inserted, and more of them can walk independently, and their urologic function is also better. Less of them have to have catheterization. However, more of them get tethered spinal cords. The fetal surgery get maybe twice as many fetal tethered cords. And so what about the mothers? It's a bit of a problem for the mothers. 65% of them have premature membrane separation. 13% have oligohydramnios. 42% have spontaneous rupture of membranes, and so that all results in more premature births. So this was a study that looked at the cost for both the mother and baby. What are their healthcare costs in the first year of life? And so here is the cost for the prenatal repair. Here's the cost for the postnatal repair. So the costs were increased in the prenatal group by several $100,000. However, this will probably be offset by the long-term cost savings in the patients with myelomeningocele, but that study hasn't been done yet. So it's costly. And it requires a lot of resources and personnel, fetal surgeons, support technologists, administration, new operating rooms, new equipment, and of course, modifications of the healthcare systems to pay for the services. This is one of the reasons why my hospital decided not to do this, because it's very costly. Maybe to make an operating room cost several $1 million to have. So in conclusion, I want to say that it's been a pleasure to be here so far in Indonesia. It's our first time here, and we were very impressed by the program, the hospital, and the university. But not only that, by the warmth of the people. So this is Dr. Astri in her office. Very proud of her, and here she is as a leader. So thank you very much for everybody, Dr. Astri.
Thank you, Prof. Aldana. Right on the spot. Thank you so much. I have lots of questions, but it wouldn't be fair if I've been the one asking questions. So I would like to give opportunities to our friends in the audience to ask questions. Please have a seat, Prof. Okay, so let me start with my question first, Prof. So I'm a cancer person. Oh, yeah? Oh, there's a okay, yes, please. You have a mic? Microphone? Okay, thank you.
Good morning, doctor or professor, should I call you? Let me introduce myself. My name is Kavin. I'm a general practitioner from Yasi Hospital. I have two questions. First of all, thank you for the presentation. It was very clear for me. So we can have a simple and clear understanding for the spina bifida cases that you just explained. So my first question is, for spina bifida cases, what are the considerations of performing surgery versus non-performing surgery? Is there any other options besides surgery, maybe medications or non-invasive procedures? That's the first question. And the second question is, what's next? Is there any exciting technology or future medication maybe approaching stem cells or other exciting technology for these cases? Thank you very much.
Thank you. Those were very good questions. To answer your first question, which is appropriate for surgery or not? Any spina bifida that is open, so spina bifida aperta, so myelomeningocele, those require surgery, no question asked. Patients can get meningitis, they can get other infections, or they can injure their existing spinal cord. So those need to be closed. For the spina bifida occulta, where it's closed, there's some room for observation, because not all of them develop problems. So if the patient has recurrent bouts of meningitis, or if there's fluid leaking, that also requires surgery. But for the lipomyelomenoceles, a certain percentage of those do not have symptoms, but it's a smaller percentage. About 30% do not develop any symptoms. So eventually, over time, about 60-70% of patients develop symptoms. So you can wait till when the symptoms occur before they have surgery. Or in the U.S., we're more aggressive. We do not wait for when they have symptoms. So we do surgery on those. It depends on your situation. For what's next, I'm not aware of any stem cell trials for spina bifida. I think there can be a lot of other things that can be done, and Dr. Ojal in her talk will talk about that. That's cheap and is easy to implement and can prevent. So prevention, I think, is the one thing. Treatment is costly. If we can prevent, is better.
Okay, thank you. Any question from the online, from Zoom? Yes? No? Okay. Yes, Prof. Pasli.
Thank you for inspiring presentation. My question about timing. Timing during the fetal life and timing postnatal. How do you prioritize the timing for the surgery intervention? Thank you.
You're right. For the timing for postnatal, there are some studies that show if you wait more than 48 hours, there's an increased risk of infection. So in our country, we try and do it before 48 hours. It would be interesting to see in other populations for patients who present late, how often those get infected. But the late closures, it's a lot more difficult. There's more scarring. You saw in the surgery that I performed, it's very easy to see the different layers. But when it's scarred over, it makes the surgery more difficult and more likely to get infections, etc. For the prenatal, there is a specific window. I don't remember the actual weeks, but I think it's somewhere between the end of the first trimester and the beginning of the second trimester. If you do it later than that, it's not advised. Yeah.
Maybe one more question from the floor? Oh, okay, there's one.
Good morning, Professor. My name is Camelia, and I'm a medical student. I'd like to ask, first of all, thank you very much for the presentation. It was amazing, and I've learned a lot. I have just one question. With the increasing use of prenatal repair for neomeningocele, following the mom's trail as well, as you mentioned previously, what do you see as the major challenges still limiting its widespread adaptation, and how might the future advancement improve outcome for both the fetus and the mother?
So what's your first question? What are the challenges?
Yeah, what are the major challenges that's limiting its widespread?
I didn't talk about it, but the fetal surgery center does not only myelomeningocele repair, but other fetal interventions, and so you need a very specialized team, and the cost to put that together, I think, are the main limitations of this. And future improvements, they're doing more minimally invasive procedures for the fetus, so there's less stress or less maternal complications with the uterus. So that's coming down the line. But really, I want to stress this is a revolutionary procedure, but really much more can be done with prevention. If you prevent it, then you won't need that costly surgery. So that's I think where we need to focus a lot.
Thank you. I'm just curious, a follow-up question, Prof. Aldana, because I knew from your work you're also concerned the practice in Philippines. How's this management of SPINA Bifida, especially in maybe low middle income countries?
Right, so it's actually very challenging, right? And that's where we need more research. Okay. Here in Indonesia, as Dr. Ojal will point out, we don't know the incidence of spina bifida. We don't know the outcomes of these late closures. There's another factor where the treatment of hydrocephalus is also a big issue. What will be the impact of prevention strategies here? Those are all, I think, very adequate and important topics that you can do now as a research university on your own for public health and improving outcomes. I think it'd be very important. Yeah.
Thank you so much. I think I would like to hear more, but the time doesn't permit us.
I would love to talk to you.
Oh,
later.
great.
Yeah,
So definitely we have to talk.
Thank you.
So please give a round of applause to Prof. Aldana. So the next speaker is also very interesting, because to follow up the issue about prevention. Yeah? Oh, you want to? Okay, obviously, yes. All right, post it on Instagram, Prof. Okay, thank you so much. So the next speaker is Dr. Ailemok Ojal. So this is very interesting figure here. Trained in Marmara University, you know the Sea of Marmara. Everybody knows the geography, okay? And gained her advanced training in Istanbul, and also to Yale School of Medicine. So she's going to talk about this for an international standard, I guess, according to WHO, how to prevent and how to manage this spina bifida. So without further ado, Prof, maybe around 30 minutes-ish, so we have enough time for Q&A.
I'll speak fast.
All right, thank you so much. Please.
Oh, it's already, okay, I can just do this. Can I actually work it from here, or do I have to wait for the slides to change? Oh, I can do it from here. Perfect, I can do it. Thank you. It is a great honor to be here in the presence of honorable, rector and colleagues. I have a unique situation because I am Turkish. I'm Turkish American. I was born and raised in a Muslim family, so assalamu alaikum. to all of you. But I went and did my studies in United States, where I have found Dr. Aldana, who is a mentor to me, and his wife, Miss Carmina Aldana, who's like a personal mentor to me, and that's how we met with Dr. Astri. It's a great honor as a female neurosurgeon who's from Turkey, who's raised in a Muslim family and work in United States. I think here I see a lot of female students, and your female students are great. They've been helping us. So I just want to tell them that everything is possible. Even if you're from underprivileged or from different countries and backgrounds, everything is possible as long as you actually go after your dreams. It is a great honor to be here. Thank you so much. So I'm going to switch the talk. It's not going to be too far away what we have spoken about, but it's a little bit different than medical. We want to talk about neural tube defects, mainly spina bifida aperta, but we want to talk about how to prevent it, maybe to answer some of your questions. And we know that we can prevent spina bifida, and we're going to talk about how to prevent and what do we do and how to champion this in our own countries. I'm here on behalf of Neurosurgical Outreach Foundation with Dr. Aldana and Ms. Carmina Aldana, but both Dr. Aldana and myself belong to many groups that advocate for child health, and including policy making, advocating at an organizational level in our country, as well as with the International Society of Pediatric Neurosurgery. Okay. I have no disclosures to make, but I also want to make a point that the first medical school was in Asklepion in Turkey. Of course, people think that it's also in Kos in Greece, where Hippocrates was, but the first medical school was named after the god of medicine, and it's in Turkey. You should go and visit if you go to Turkey. Okay, so my hospital and university is actually in a very small state when compared to Florida and Texas. And our state is also a very low middle income, socioeconomically low income state where health literacy is not good. We have very far away communities, and we have very poor communities as well. And this is my university, and then my children's hospital is a freestanding hospital away and separate from the university. So I'm a faculty at the university, teach, but I also serve at the children's hospital, where we serve to 1.5 million children in the state. It's never near comparing to Indonesia, where there's a lot of population, a lot of young generations, a lot of children. And it'll be more in 2030 when you look at the Sustainable Developmental Goals and populations. So we know that neural tube defects can occur when the neural tube, it fails to close. And as Dr. Aldana mentioned, there are types of spina bifida. Spina bifida is aperta, is the myelomeningocele myeloschisis, which is the incomplete development of the spinal cord. The anencephaly is absence of major portions of the brain and skull, which is different. The encephalocele is herniation of the brain through the defect. So there are types of spina bifida. Mainly we're talking about myelomeningocele or spina bifida aperta, but we need to keep in mind that there are different types, including occult or closed spina bifida that we have spoken about in the first talk. These are my patients. The last one is actually a patient from here, Indonesia, and it's given to me by a friend. Should I use this or this one? Continue to use this one. Okay. So spina bifida, which is the main topic of this session, is myelomeningocele. It remains to be the most common congenital central nervous defect. And by looking at the research, I know that it is the second most congenital defect in Indonesia as well. Our main message is, because spina bifida is a main global topic, our main message should be looking at the common and devastating birth defect in a different perspective. And we know that majority of the spina bifida is associated with lower maternal folate levels. And we know that spina bifida can be prevented by fortification of staple foods, majorly wheat, flour, maize flour, rice, or salt. So these are the main messages that I want you guys to keep in mind and go further from here. Okay. So, are you going from there, or am I going from here? Fair enough. So we don't know the incidence and prevalence of spina bifida because even though we know it's one of the most common birth defects, its estimated number in the entire world is about maybe more than 300,000 cases worldwide per the World Health Organization yearly. We know that it varies amongst the regions, countries. Recording and registrations are very, challenging. There are not a lot of good registries in especially lower middle income countries. Therefore, we do not know the real incidence worldwide. It is difficult to estimate. Most of the, data for spina bifida comes from the, higher income countries, usually North America and Europe. It has been estimated around 100,000 fetuses affected annually in China, according to their records. Maybe 0.2% in 1,000 live births in Japan. In the United States, it's about like 1 to 2 per 1,000 live birth. In Sudan, it's 2.8 because they don't know their incidence, so it's very difficult to estimate. As I said, I was looking for the prevalence and incidence in Indonesia. Unfortunately, I was not able to come up with a good number. I'm hoping that you can provide me with that number. And I know with the country's situation and population and the communities that are spread out, it may be difficult to find the incidence in Indonesia. Again, estimated prevalence in the world is anywhere between 2,000 to 300, which is approximately 2,000 out of the 1,000 live births. But are we counting all of the spina bifida affected globally? Even that incidence and prevalence, I don't think it's accurate because we're just seeing the top of the iceberg. We're seeing the live births, but we're not counting the misclassified neonatal deaths in registries. We do not count the stillbirths because nobody counts for them. And then we do not know how many elective terminations are there. And we do not know how many early fetal losses are related to neural tube defects. So we do not know how many pregnancies, how many women are affected from spina bifida. Globally, when looking at the numbers, we only know what is reported in higher middle income countries. Globally, per the WHO, every year about 130,000 pregnancies are affected by the spina bifida globally. And we know that 50% of them will result in either stillbirths or live-born babies that die in early childhood. Babies born with spina bifida have a long life with neurological impairment, and they require multiple surgeries. We tell that spina bifida is a devastating disability, but I want to acknowledge that with the advance of technologies and good care, our spina bifida babies are now living towards adulthood. So that increases the need for their care long term and may increase the burden on the healthcare system. I have patients who have spina bifida and who maintain a good life and schooling. So this is no means to discriminate against disability or children with disabilities or families with disabilities. But nonetheless, spina bifida is a devastating birth defect. And we know that affected children, not only children, but their families also face a social dilemma, stigma, burden, psychological, financial burdens, in addition to the disease itself. The cost of medical care for spina bifida is very high, and cases are never curative. So we don't cure spina bifida, we just treat spina bifida and provide long-term care, which affects how actually the cost of this disease is added to the healthcare systems. The treatment is surgery, so we're not going to talk about that. We know that there are lifelong problems, including hydrocephalus, spinal orthopedic problems, with cognitive issues, with schooling disability. The lifetime risk of death is 10 times higher in a spina bifida patient when compared to a normal baby. The 1-year survival rate among infants with open neural tube defects is almost 90% in lower middle income countries. Before 1960s, all these babies were almost dead. It was a death sentence. And fortunately, nowadays, it's not a death sentence, but there's still a lot of problems that we need to solve. And it comes down to the resources, how much resources that we have, how much that we can spend for these babies to care for them appropriately in the high quality standard of care. And we know that severe disability can occur in 33% of these patients. We need to think about the future with these babies becoming an adult and living as disabled adults. So the economic cost of spina bifida is very high, given all these expenses, direct costs and indirect costs. The direct cost is to the healthcare system, with healthcare expenses coming from direct medications, surgeries, ongoing medical care. In addition to that, there's specialized care with rehabilitation, equipment, such as wheelchairs. It's very costly. And then we need to think about the indirect costs with loss of productivity as an adult, a caregiver burdens. A family who needs to stay at home to take care of their baby may not be able to work or do the other things to provide for their family. And of course, the social and emotional impact of having a baby or a family member may affect the families in an adverse way, which then requires further care. A depressed mom cannot provide for her babies. Maybe a burdened dad cannot go to work and properly work and provide for his family. So it adds to the system. Of course, the prevalence, the severity of the condition, the access to healthcare, the socioeconomic factors add to that burden. The economic cost of spina bifida in the US is high. One stay for one infant in the first year of life because of spina bifida related condition, that can be a wound problem, that can be hydrocephalus, that can be orthopedics problem, is about 20,000, depends on the severity of the condition. So this number can go from anywhere to 96,000 for just an outpatient visit to $1.3 million for a patient who has complex needs and complex disease conditions that require a longer stay in the hospital. In the first year of life, we have babies that stay in the hospital for about average of 14 days. That's a lot of burden to the economic system at the healthcare. So how do we mitigate the economic burden? And coming back to the questions before, of course, prevention, early intervention, community support and community awareness, and research and innovation are the mitigating factors for economic burden of spina bifida or any other chronic diseases. But especially in spina bifida, the most important thing is prevention of this disease, because this can be done. So prevention, prevention, and prevention is the most effective, safest, and cheapest treatment for spina bifida, to our knowledge nowadays. Hopefully this will change in the future, maybe with the stem cell therapies or genetic changes or genetic factors. But at this moment, the best tool that we have is prevention of spina bifida with the cheapest tools that we have. We know one of the risk factors of spina bifida that we can prevent, and which is the main message that I want to give to you today, is low folate levels in the mother before and during early pregnancy. And unfortunately, this comes from low socioeconomic status, meaning you don't have access to healthcare, you don't have access to prenatal care, you don't have access to prenatal counseling, you don't have access to care or food, which then causes a lot of impact on your baby's health, as well as the mother's health. We have a solution for this, and this solution has been around for more than 30 years. The solution is to provide all women of reproductive age with just 400 micrograms of folic acid a day, which is vitamin B9. This can be through diet, this can be through folic acid supplementation pills, and which is the cheapest way of doing this is to fortify staple foods with folic acid. WHO, the World Health Organization recommendation is 400 micrograms of folic acid daily for the first 12 weeks of pregnancy. But this should start before a family decides to have a baby. Now, it doesn't work unless you start at an early time, which is at least 3 to 6 months before you plan for your family, before a mother, plans for conceiving. And we know that women who had a fetus diagnosed as, affected by a neural tube defect needs to have more information of the risk of recurrence. They need to be advised on the protective effect of periconceptional folic acid supplementation. They need to be advised of taking a higher dose of supplementation if they have a baby already with spina bifida. And they need to be advised to increase their food intake of folate. With all these, we can make a huge difference in the life of these mothers as well as life of these babies. The WHO started the guidelines and established the guidelines in 2009 initially, and then revised it in 2013 for the prenatal care and folic acid fortification. The folic acid fortification of foods has been adopted by 60 countries that have mandated the addition of folic acid to flour, to wheat, to maize products, and to rice. It's been already has been associated with reductions in the prevalence of neural tube defects. We know that in Brazil, in Canada, in China, in Argentina, in South Africa, there is more than 30% of reduction of neural tube defects by folic acid fortification. In Chile, it's about 40% of reduction. In Canada, it's 46% of reduction. So it's very important to have a prenatal consultation and prenatal care. It's also very important to have a prenatal evaluation. We were talking early before, prenatal counseling is very essential. Lack of prenatal care in the term of finding ultrasounds, doing every trimester checks is very important. We can catch spina bifida as early as the 16th week of gestation and start preparing the families for a baby that will be born with spina bifida. I did a study on prenatal diagnoses and prenatal counseling. The family, even though it didn't change what the outcomes might be, the families come back to say to us that a prenatal counseling increased their perspective. They were more aware of what to expect with their babies. Therefore, their visits to the emergency room was very minimal when compared to a family who did not get prenatal counseling. So I believe that prenatal counseling is very important in addition to prenatal care, in addition to folic acid supplementation. And it is very important to emphasize again and again that the critical period for folic acid fortification and prevention is prior to conception. Because we know that the neural tube starts forming around the 3rd and 4th week of gestation, and we need to catch our families, our mothers, before that 3-4 weeks, before they even know they're pregnant. So it's important to start the folic acid fortification or supplementation before. Not everyone has access to a pharmacy. It may not be as cheap. Not every mother has access to prenatal vitamins. I know in Indonesia, the government makes it mandatory and you supply the families with prenatal vitamins and nutrition. But it may still be difficult to get to everywhere in the country or in other lower middle income countries. Therefore, fortifying the food that we consume is the cheapest and most effective. So what is food fortification? It's basically an enrichment. It's the addition of vitamins and minerals to foods during their processing. And it is very easy, I'm told. We work with Food Fortification Initiative, we work with Nutrition International, and when I listen to the experts about how to fortify folic acid, it sounds very easy for me. But I think the problem is distributing this knowledge, distributing the folic acid toolkit or this vitamins, not only folic acid, but also iron, also like zinc, all other micronutrients to the little millers. Because in some countries, the flour is milled by the little millers and little industries rather than big, huge industries. How to get to them is the problem. We can mandate as much as we want in countries like US, like Indonesia, like Turkey, like Philippines, but if we don't get that tool or knowledge to the little millers in a village, it's not going to work. And that's where we see most of the babies with disabilities or with prenatal defects. 80 countries fortify wheat flour, 18 countries maize flour, and 11 countries fortify rice. The research is being done on salt fortification in addition to ionization of the salt in some other beverages and drinks that the public consumes, also in milk and yogurt products in some countries. Folic acid fortification is proven, it is safe, it is cost-effective public health intervention, but unfortunately it's vastly underutilized worldwide, and that is what we want to change. One country, one community, another. Only 23% of all preventable spina bifida globally is prevented over the 30 years that we have this knowledge. We did not do a good job. Therefore, we need to work more. Therefore, we need to have more champions in the country from the communities. Indonesia is there. It has moderate prevention, even though Indonesia is doing folic acid fortification, including iron fortification and zinc fortification in the food since 2001, I believe. Today, around 60 countries do mandatory, but the rest of the countries that we say is either voluntary or they don't really use it, and it may be just randomly or in selective cases. There is very strong evidence for the safety of providing folic acid, because one of the questions, especially when we go talk to the Ministries of Health or when we go talk to the Ministry of Agriculture, is safety of folic acid. It is absolutely safe. There is strong evidence for the safety of providing folic acid through fortification of foods through multiple studies globally. There is no scientific evidence of masking vitamin B12 deficiency, increasing risk of cancer, or causing other adverse health conditions. And when we fortify with small amount. We don't fortify with a huge amount that would cause any side effect. So it's absolutely safe. With the fortification, we can decrease the neural tube defects about 41%. This includes doing with the rice, doing with the wheat flour, doing with the maize flour, doing with the salt. In Chile, when the folic acid fortification was used, they were making $2.3 million international dollars savings instead of taking care of a baby with spina bifida that would cost healthcare system more than that. In US, by doing folic acid fortification, we're saving $603 million every year. So folic acid fortification is cost effective in addition to being safe and in addition to being simple. National mandatory food fortification promotes health equity in the population and is highly cost effective. So it's actually very aligned with the World Health Organization's Sustainable Developmental Goals for 2030. We prevent a death, and which prevents us $950. We prevent a disability-adjusted life year, $15 a day in the time of a patient. So it's a lot of money. Cost effectiveness of folic acid fortification is similar to other life-saving interventions like rotavirus vaccines, like malaria, like vaccination for measles. So it is high up there, but unfortunately we do not pay enough attention to folic acid fortification when it comes to other communicable diseases. 1 year of fortification can save $32 billion in selected lower and middle income countries with the high potential to fortify. And we can achieve that by doing all of it, by doing with salt fortification, by doing with wheat fortification. We can add on top of it. However, in order to prove effectiveness and in order to prove that this is cost effective and working for your country, what we need is national registries. We need a systematic review in every country. And this is very difficult to achieve. As I said, most of the interventions and the publications, data comes from higher middle income countries such as United States, Canada, and European countries. We need more information from other countries so that we have an understanding of global effect as well as global cost effectiveness when we do prevention. So we need a prompt global action to mandate folic acid fortification, not only in 60 countries, but another 130 countries. WHO, World Health Organization, and the World Health Assembly has 197 members. And out of that 197, only 60 mandates folic acid fortification. They can mandate, but it becomes a big problem for implementation. Even though 60 countries mandates it, they may not be implementing it well. The science and benefits are clear for food fortification. It's a great public health policy that every country should adapt, and it has a high benefit. For this defect, we've seen this deficit in the global community when we were around. And as I said, Dr. Aldana and myself are members of Global Alliance for Prevention of Spina Bifida. This was a group of multidisciplinary professionals, including pediatric neurosurgeons, including millers, including pediatricians, including community leaders, including ministries of health and their health workers, including nurses. So it's a huge group that started meeting in 2020, right before COVID. Certainly, COVID kept us a little bit away from what we wanted to do, but starting from 2020, our goal was to prevent spina bifida and to decrease the prevalence to 0.5 per 1,000 births by using folic acid fortification. There's a lot of support, and the last support came from UK, the UK started mandating folic acid fortification just recently, a couple of years ago. And for this, we decided that we should go big, right? You go big or you don't do things. Unfortunately, it took us a few years to get to the attention of World Health Organization, but we were able to bring what we wanted to do with the sponsor of Colombia and sponsor of US, as well as Pakistan and Bangladesh and Ethiopia. We were able to bring this goal and this resolution to the World Health Assembly in 2023. Because there is no need for any more evidence to say that it's safe, cost-effective, it's a great public intervention, and it's underutilized. So we thought that World Health Assembly will help us to bring this as a resolution, which then mandate more countries or be guidance to the more countries, more member states to adapt it. So we wanted to create awareness, we wanted to generate a political will to act, and we wanted to ensure governments implement and sustain prevention by getting WHO behind our back. And we actually approach in a way that, prevention of spina bifida is aligning with the Sustainable Developmental Goals of 2030. It decreases disability, it decreases stillbirth, it decreases child mortality. But in addition to that, by doing folic acid fortification, you can help with poverty, you can help with hunger, you can help with education. It brings gender equality to females who need access to good food, staple foods. It also helps with inequality. So it's not only aligned with the health goals of the sustainable developmental, but it also aligns with bringing health equity, health for all to the nations that require it the most. There are a lot of organizations supporting this WHO resolution, and we were able to go to Geneva in 2023 and was able to pass this as a resolution, which is named as Accelerating Efforts for Preventing Micronutrient Deficiencies and Their Consequences, including spina bifida. In this resolution, spina bifida was named specifically with the efforts of this group. The World Health Organization World Assembly 7919 passed in 2023 and was unanimously accepted by all the member states, which is, I think, a proud achievement for the neurosurgeons, in addition to all the community leaders. This is our group in Geneva, and this is passed. It was, I think, most easy thing was to pass the resolution, but the difficult thing for me and to understand and bring all the communities together and create a political will and force the governments to act on it is the most difficult part. The implementation of this resolution is an important part of it. Because WHO is a very important body that provides guidance for countries and member states, but unfortunately it doesn't mandate anything. You can follow it or you choose not to follow it. But I know that Indonesia has been a champion of folic acid fortification in addition to iron and zinc in the wheat flour, and I believe in the rice as well, since 2001. They aimed addressing micronutrient deficiencies, particularly among vulnerable groups. This initiative was a part of the government strategy in Indonesia for large-scale food fortification, including cooking oil as well as salt, I believe, in addition to wheat and flour. They revised this, fortification guidelines in 2018 because it was below the level of WHO recommendation, and they brought it to the WHO recommendation in 2018 and started implementing it as 2021. However, even though you're implementing as a mandatory, I think it's difficult to reach to the small millers in small villages, so therefore implementation is difficult in Indonesia. It's also because of the geography of the country. The regulations and checks needs to be there and continuously needs to be done, and the registries need to be in place. So I trust that all the great minds here will continue to push this in research, innovation with the technology that you have and resources that you have. I've seen a lot of good resources here in your university, and I believe that you will be a champion in this in the next few years. So I want to show you one little thing before I close. I found this paper that was published in 2023 by Nutrition International. And if you do not act in Indonesia for implementing folic acid fortification with other nutrient fortifications to your staple foods, you will lose about $279 million by 2030. And that's proven. That's a cost analysis projection that Nutrition International did for your country. So if you start implementing and acting now, which what you have already, you will save a lot of money to your healthcare system, which then be used for other things such as education, such as other public health prevention. Become the champion for spina bifida prevention in your country, like you all are. And knowing is not enough. We must apply our knowledge. Willing is not enough. We must do. We must take action. Thank you so much for listening, and thank you so much for having us here.
Thank you, Dr. Rojal. I would like to hear a comment from Prof. Fasli. Prof. Fasli has been trained in Cornell as a nutritionist and is very involved in the Indonesian national program, especially with the Makan Bergizi Gratis. Prof, please give us what's the overview, the challenges, because you have been involved in so many things in nutrition. Please.
It was a difficult challenge to talk in front of an expert. I hope I did not say anything that I shouldn't be saying.
No, thank you for thought-provoking ideas and inspiration and also suggestion. We have been doing, for food fortification, as you mentioned, long time ago. But one of the most important program in Indonesia for pregnant women is giving the iron and folic acid tablet as supplement. We provide minimum 180 tablets for every 4.5 million pregnant women every year. No problem with funding, no problem with distribution to the closest health center, but the problem is going to the family and the willingness of family to eat it up. So 2018 we have studied only 36% of the pregnant women eat up to the 180 tablets, even many of them below 90 tablets. So now we are trying to do the second thing by doing multiple micronutrient intervention. But still, the delivery, the demand side, and also the monitoring, even though we have regulation. My question to you, how we can come up with the more focus on the folic acid, because folic acid is just additional in our whole nutrition issues, because it's just adding to the iron supplementation. But based on the presentation on spinal bifida and all implication for the brain development, etc., I think we need the new entry point to enhance the policy and also do the correct implementation, monitor it and evaluate it. Thank you.
That is a great question. As I said, it's difficult to talk in front of experts like yourself. So that is a very difficult thing to do, because most of the countries do not take folic acid fortification as their main problem, because iron deficiency anemia becomes the most important and most prevalent thing in some of the countries, most of the countries. Even when WHO decided to pass this resolution, they did not want to separate folic acid from the other micronutrients. So they passed it as micronutrients in addition to folic acid. I do not know how to separate the folic acid fortification and focus only on that and separate it from the micronutrients, because everything is needed. One thing, as you said, which Indonesia does, is providing folic acid supplementation pills directly to this. But I think we know the answer. It's just we need a little bit more political will to push this agenda and bring it to the communities, involve the communities themselves to make them more literate about healthcare and prevention and disabilities and their babies. If we find why they're not taking the pills, if we find what they want, if we find what their hesitation, is it the community, is it the color, is it beliefs, is it religion, I think we can come to the bottom of the root cause analysis of the problem, and then go on top of it with more focused community approach only for folic acid. If you want to separate folic acid, I don't think that's going to happen. But we can try to implement it with other micronutrient deficiencies and put it into the political agenda of the governments. That's the only solution that I can find at this time. I've been looking and reading about this for a long time. Dr. Aldana? Phil?
I just had one comment from your comment. You describe a problem of compliance of the mother to take the pills. And I had this discussion last night with Dr. Oscar about just the patient's own beliefs preventing them from following the advice of the doctor. That's why I think it's so important to have mandatory fortification of staple foods. So you remove the issue of compliance and just make it automatic. And the other thing is a lot of women don't anticipate getting pregnant, and so they're not going to take the pills, or if you give the pills when they're already pregnant, it's too late, because it's you know, in my talk, 3 weeks and the neural tube is already done. So the answer is you have to have the foods in your very tasty rice dishes or salt, so everybody's taking it, and you don't have to take the pills. That's just my opinion. Yeah.
I think it needs to come down to the communities. We have communities that are separate. We have communities that do not trust the maybe modern healthcare system. We have communities that do not like the color of the wheat when it turns to a little bit of a yellow with folic acid or iron. So it comes to education of the communities with local leaders. So there has to be a buy from local leaders, community leaders, elders in the families, as well as government officials and healthcare professionals. It's not one man's job. It requires the entire village to take care of this.
Okay, one more question. Yes, please. Okay.
Thank you very much. Hello, doctor. Thank you very much for the presentation. My name is Amali Ramadhani. I'm a general practitioner and also an intern at Surgical Oncology Department at National Cancer Center Hospital, Darmais in Jakarta. I'd like to ask you a question. I'm sorry if it's a bit out of topics. So I read on some journals before that talking about the fetal or prenatal surgery for spina bifida patient, that they said it involved repairing the spinal defect before 26 weeks of gestation. Is that true that we can do the procedure now? And is it really effective for potentially minimize the severity condition of the baby with spina bifida after birth? Thank you very much, doctor.
That is very true. Actually, in 2010, the study, the randomized controlled study of the myelomeningocele closure in utero closure have been published. So since 2010, we know that in selected group of babies or mothers, the in utero closure is effective. And the timing is, of course, there's a lot of inclusion criteria. Not every mother is a good candidate for it. And when you present it to the mothers, I cannot really see any women to say no to this procedure because it's proven that it's effective postnatally. When compared to postnatal closures, the prenatal closures or in utero closures have decreased risk of sensory and motor deficits about 1 or 2 level. Meaning if your baby has a lumbar 4-level deficits neurologically, we're not counting anatomically, they may have better outcomes. In studies up to 5 to 10 years now, it also shows that their urological problems are better with in utero closure. So it's proven very effective. The most effectiveness is seen in hydrocephalus, right? Babies who are closed in utero have 40% less, excuse me, risk of having hydrocephalus, therefore requiring another intervention. When compared to postnatal babies who are, our textbook knowledge is 80% that they need hydrocephalus surgery. So it decreases that about 50%. These are all well proven and established, outcomes for patients who have in utero closures. It is difficult for the mother, but it's more beneficial for the baby. And it needs to be done between 19 weeks up to 20 weeks. So you can do it as early as 20 weeks up to 26 weeks of gestation. And the optimum time is, like we were saying, is about 22, 23 weeks of gestation. Not every mother is a candidate. There's a lot of risks, complication, but knowing what we know over the last 10 years and in advances, the risk to the mother and the baby has been decreased as well. So it's very proven that in utero. However, again, it's expensive. Like Dr. Aldana is looking. I do not have in utero closure unit in my hospital. Even though we have resources, we cannot afford it. And not every family can afford it because it's not the standard of care yet. And therefore, some families need to pay out of their pocket to have this. It's an expensive, very costly, with a lot of good outcomes. But we cannot provide it to every baby, and not in every country. So again, going back to my talk, prevention is much cheaper, $10, when compared to $1 million for in utero closure. So you do prevention rather than in utero closure. That was a great question.
Thank you so much, Dr. Ojal, for a nice, interesting session. So, one more? Okay, please.
In terms of registry and also how we Indonesia can come up with a robust prevalence study or incidence study of SPINA bifida.
That is a great question. And as I said, I'm trusting on the very highly, minds over here, that you will be able to do that. It is difficult, especially in countries where the communities are spread and where there's not a lot of registration system at the local level. I think it's very difficult to find the real incidence or prevalence because we're not counting the stillbirths or births at home or births not in the hospital as well. One thing that may help is including, again, the local midwives, local nurses to register that. I think they're great resources. With the technology that we were talking today, they can maybe do it on an app or in a, on their phone because you have internet connection everywhere. The government has to guide this. It has to be a government implemented registry with maybe use of electronic medical records, electronic system, and reporting back through the communities. It can be solved, but it is difficult. It requires a lot of personnel. It requires a lot of will on the healthcare provider. It may take from their busy schedule of the day, but unless you have the will, you're not going to be able to do it. And it requires midwives, nurses to start with, and then the general practitioners, and then the surgeons, and then all the other healthcare providers. But it has to come from the top. It's a top to bottom and bottom to top approach together. I believe electronic health records, AI interventions, the technology would help at the end. But there's not a big solution yet.
I think to add to that point, you can start small, just here in your community around Yarsi University or in Jakarta. And if you can prove that it works in Jakarta, then you can put it in other cities. And maybe not plan to have the whole country at the same time, but city by city, region by region, but start here first.
Let assume we have the one district with a population of 1.2 million that very close to us, and we have a lot of outreaching program there. So given the population and the accessibility to us, what kind of the design of the prevalence study in that region, if we can afford it?
The one thing is just like looking at, of course, prevention of folic acid, right? We have people who does that for us in terms of research. In this group with the Global Alliance, we have resources that can help countries to start their registries and to look at pilot studies with small group of people, looking at your maternal health centers and gather normal blood levels from there, right? So we start with folic acid blood levels in mothers, that's one thing. And then we follow those mothers that come to these maternal health care centers for their care. And then we follow them through and compare them to another region where there's not a lot of folic acid. So I think if you have help, I know that you have maternal health care centers that can do this at the very basic level. And salt is very, very important. I believe everyone consumes salt nowadays. Looking at salt fortification and doing comparative studies is another way to go. Starting with small communities, prevalence 1.5 million is a good number, right? You know, you can look into registries, you can look into like schools, you can look into like in clinics or general practitioners, their offices, because they actually see these babies, pediatricians, involving all of them to register back. So I don't know if there's any easy way to do it, but it can start. Once you start, I think it'll come. Certainly we have people that can help if the university wants to have a collaboration.
Right. Well, I'm kind of interested when it comes to the blood level of the folate, right? Because you mentioned the standards, but 1,000 nanogram per mil. So that should be doable, because to also answer the question of compliance, because if the blood level is not reached, then you know they're not eating what they're supposed to eat.
That's right.
Is it something that you're done? Or
Yeah,
okay.
you know, me personally, but the group that we belong to has researchers that have done that.
Okay.
And they have done it with Ethiopia. They are doing it with India, with the salt, and they're doing it in Bangladesh. So it is doable with pilot studies. So there are researchers dedicated to look at these pilot communities and look at the folic acid.
Okay. Prof. Aldana, you want to add something?
I think we can talk about this later, so we don't
talk about spina
but this
bifida
is
all day
very, very interesting. I think the baseline is you have to determine just the baseline prevalence that and identify the cases, and then you can go from there. Why these cases are occurring, regional variations, differences in maternal attitude, access to medicine. There's so many things that you can do.
One basic study that we decided to do was in Turkey, but Turkey went, switched to electronic health records. Not everything is recorded normal, well. You can just find a lot of things on their spina bifida, but we went back to look at those ICD codes, like registration codes from every healthcare or every hospital. And we were able to find it. We don't know if it's accurate, unfortunately, but at least we have an idea of what the prevalence or incidence would be by looking at the codes that these doctors or hospitals registered into the Ministry of Health system. If you have a healthcare system like that, then it may be easy to look back to look at that diagnostic code to figure it out. It may not be accurate, but it'll give you an idea. Yeah, it'll be a start.
Besides folic acid consumption, is there any other predisposition or exposure to the chemical environmental?
The most important thing and the one thing that we can prevent is folic acid levels, but valproic acid, diabetes, other iron deficiencies, other micronutrient deficiencies are also risk of spina bifida. I didn't mention them much, but valproic acid, seizure medications in communities. There's no a chemical exposure that we can directly say one or the other way, but we know that diabetes, with other nutritional issues, can cause spina bifida. Anything from environmental, we have a lot of environmental pollution, but it's not proven to cause spina bifida, though it causes some other birth defects and respiratory problems in neonatal. That is very established, but not one chemical factor that causes it.
Thank you so much. Please give a round of applause to Dr. Ocha. All right, we have one more session, but it's even more interesting, at least for me, because we look at the genetics part of it. So the next speaker is Prof. Sultana Faraj. She is trained as a medical doctor at Universitas Diponegoro, and she went to Australia, New South Wales, and studying genetics there. We're going to learn from Prof. Sultana some of the genetic issues in neural tube defect. Prof. Sultana?
Everyone, Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to thank to the committee to invite me to join this event. and also to Dr. Amy Okta. You already talk a lot, so I just part of your talk. Okay. Yeah, neural tube defect or NTD is a birth defect on the brain, spine, and also spinal cord. It happened in the first month of pregnancy. Remember, first month of pregnancy. Before a woman even knows that she is pregnant. The presentation of NTD might vary from anencephaly, encephalocal, meningocele, and also spina bifida. Spina bifida is influenced by a combination of genetic and environmental factors, with genomic studies playing a crucial role in understanding its complex etiology. Some genetic mutation can cause spina bifida, but they do not account for all cases. There are three types of spina bifida. Spina bifida occulta is the mildest form, where there is a small gap in the spine, but the opening cannot be seen on the back. Brain and spinal cord are normal function. There is an asymptomatic bony defect. Spinal defect is covered by skin with hair and red color. Maybe you can see the picture with red and red colors. There is no walking difficulties in the spina bifida occulta. Spina bifida cystica or meningocele is a severe form. Case containing spinal cord protrude through the spinal opening. A sac or the keys is visible on the baby back. Myelomeningocele, the more severe form, the spinal cord protrude, forming a sac or a keys. The spinal cord itself is within the sac. Yeah, this is some of the picture. The spina bifida occulta, yeah, with hair on surrounding of it, and also the myelomeningocele. And this is the picture of anencephaly. The head end of the neural tube fell too close, usually during the 1 month of pregnancy. Sometimes maybe some reference said less than 1 month, yeah? Resulting in an absence of a major portion of the brain and skull. The next one is the encephalocele. In this spina NTD, brain tissue protrude through opening in the skull, resulting in a skin cover sac outside the skull. An encephalocele can be located in the base of the skull, can be also in the nose or sinuses, or also forehead, and also on the top of the skull at the midline. Etiology and pathogenesis of NTD actually influenced by nutritional factor, genetic factor, and also environmental factor. Folic acid influence methylation of DNA and histone modification. folate deficiency down-regulate expression of neural defect closure. Maternal folate deficiency preconception in the first trimester. Whole exome sequencing or whole genome sequencing and targeted panel sequencing study reveal mutation in some gene associated with gene candidate for neural tube defect development. And from the environmental factor, arsenic is cytotoxic and teratogenic effect. Pesticide accumulate in adipose tissue and placenta. Maternal hyperthermia disrupt mitosis and gene expression. And also drug such as anti-epileptic drug and NSAID. The exact cause of NTD are not known. Can be genetic, can be epigenetic, is environmental factor and nutritional factor. Can be also poor intake of folic acid or vitamin B9, and obese woman or diabetes, and pernicious anemia or megaloblastic anemia with deficiency of vitamin B12. Intake of specific medication during pregnancy such as valproic acid for anticonvulsion or epilepsy, spiramycin quite often used in Indonesia especially for the toxoplasmosis infection and usually given since pregnant for several months. So this is also influence to the deficiency of folic acid. Several gene and genetic factors are associated with an increased risk of NTD. Mutation in the gene like RF6, VNGL1, VNGL2, FUS, CLSL1, and TBXT have been identified in relation to Spina bifida. Additionally, genes involved in the folate metabolism, particularly methyl tetrahydrofolate reductase or MTHFR. The MTHFR A1298C gene variant is a common genetic variation. This variant is associated with reduce of MTHFR enzyme activity, but generally has milder effect compared with the C677T. This is according to the National Institute of Health. The enzyme MTHFR will be reduce the activity if they have a variation on 677TT homozygote. It is the other one also increase the homocysteine in the individual with homozygote of 677TT. The disturbance in the remethylation of homocysteine to methionine due to folate deficiency increase plasma homocysteine level. You can see from this, sorry. Mana ni? Yeah. Yeah. I just want to show you this graph about homocysteine and methionine in here. If we have less enzyme activity of a methyl tetrahydrofolate reductase, so the homocysteine cannot be recycled to methionine, so the homocysteine level become high, or high homocysteine is actually also influence to cardiovascular disease. So in here, vitamin B12 and B6 play a crucial role as cofactor in folate metabolism. That is the reason maybe for the folic acid vitamins should have also B12 and B6. Let me give the example of our case. This patient have the first and second babies with neural tube defect and anencephaly. And in the third pregnancy, we give a high dose of folic acid supplementation since preconception. Yeah, since preconception resulted in a normal baby. I want to show you in this methyl tetrahydrofolate gene analysis. Actually, we found CT heterozygote. In most of the published paper is homozygote, CT homozygote, but in our case is heterozygote. Just show you this testimony from our patient because their third baby is normal with supplementation of 5 milligram folic acid before conception. And the second case, just the recent one, is actually the patient from Dr. Astri. He has also myelomeningocele, and this is the third child of the 27 years mother. And look at from the mother is very pale, and we suspect maybe the mother has pernicious anemia, but we cannot get more blood from her to examine the blood smear. So if they have a pernicious anemia, often caused by vitamin B12 deficiency, and will demonstrate red blood cell macrocyte and hypersegmental neutrophil, along with anisopollicocytosis as a characteristic of megaloblastic anemia. Unfortunately, we couldn't get the blood smear from this patient. This is the result of his methyl tetrahydrofolate gene testing in our laboratory. And again, we found also a heterozygote in C77T, but also in 1298 heterozygotes. So the mother has two heterozygote in both variant of methyl tetrahydrofolate gene. And recently the baby died. A gene implicated in neural tube defect, FNGL1 and FNGL2, these genes are part of the planar cell polarity pathway, which is crucial for cell and tissue organization during development. Mutation in these genes, particularly FNGL1 and FNGL2, have been linked to neural tube defect. For methyl tetrahydrofolate reductase, I already mentioned with our cases, yeah, they have two different variants. It's actually associated also with neural tube defect. Gene involved in the neural tube development actually now already available gene panel for 191 gene for SPINA bifida typically include gene related with neural tube development, folate metabolism, and also PCP pathway. So it's quite a lot already. The key genes have been identified from the study of 191 genes. Actually, MTRR gene, CC2D2A, IC2, and TGIF1. So methyl tetrahydrofolate are associated with folate metabolism and as a potential risk. Just show you this, so many genes already found as a panel gene. I'm not going to tell one by one, but you can see that they come from so many different research in the world. And this is also the second one. This is, we have to work using NGS. Continue the story from Dr. Uklara. Folic acid supplementation for pregnant women has become not really a national program, but already been used in pregnant women since 2002. What happened at the time, I really feel sad, yeah, when the OBGYN sent to me to do the chromosomal analysis for patient with NTD, because we will not find any abnormality from chromosome analysis. Then I actually personally think that we have to give the counseling that the parents, especially for reproductive mother, we have to tell that they have to take the folic acid. But at that time, there is no folic acid available in the pharmacy. And then we did the proposal to our Indonesian FDA to have folic acid. But it's a bit funny. When I made a proposal for 0.4 milligram, 1 milligram, 2 milligram, 4 milligram, and 5 milligram, they did not agree. They said, this is only vitamin, why too high dose? So only approved for 0.4 milligrams. But I'm happy at that time because most of the OBGYN use it, and also pregnant women aware that they have to take the folic acid. Yeah, but now it's available already even in the health center. And just recently we have the 4 and 5 milligrams. But many of them did not really realize or aware that taking the folic acid must be before conception. So usually it's around almost more than 4 weeks pregnancy, they take the folic acid. So I mentioned here, for the repeated NTD, for parents who have more than one child with NTD, we propose to give a 10-time dose of folic acid, so about 4 milligram or 5 milligram. And at that time, when we have only 0.4, the patient is really refused. Why is so many 10 tablets they have to take? But now we have 4 and 5 milligrams. So thank you.
I'm not going to let you go, Prof. So until we have this Q&A session. Yes, it's a very interesting story about the folic acid, because Professor is among the pioneers to recommend this taking supplementation. So any question from the floor? Yes, please. This the interesting part when experts asking another expert. Please, Dr. Chow.
I mean, it's an honor to be, in your presence and listening to your talk. There are environmental factors, but do you think that the climate change, especially the change in Indonesia with like the flooding and water rising, any effect of the climate will affect the birth defects or no? Like hyperthermia and, do you think that would change any prevalence or incidence of any birth defects?
I do not have data. In our country, it's not like in your country, maybe in the summer can be 40 degrees or more. Yeah? In our country, usually in daily life, especially in the summer, we call not summer, it's actually what musim panas. Usually less than 40 degrees, around 35 to 37. But I think in the country with 4 seasons, in summer, usually more than 40, can be 45. Yeah. So I don't think so that hyperthermia influence to our pregnant woman.
Thank you.
While waiting for a question from the floor, I would like to ask the question about the list of genes that you mentioned, Prof. I'm sure we're not going to memorize the genes, but are there any instances where you find, or from the literatures, there are families who have these repeated cases of neural tube defect that maybe is it from the mother or the father, or is it mostly de novo mutations, which are usually more common genetic mechanisms?
Yeah. I think mostly from the mother, because the problem with deficiency of folic acid actually from woman. Pregnant woman. It's like the recent cases from Dr. Astri, we found 2 different heterozygote mutation, and she looks very pale, looks not very healthy. So maybe because of her, she has this variant. So during her pregnancy, she has folic acid deficiency or poor metabolism of methyltetrahydrofolate reductase gene. I think so. Mostly from the mother, but the mother come from where we do not have the reason. From the generation before her, we do not know.
Oh, okay.
Yeah.
Also, the mutation actually. How about the mutation in the baby itself? So
yeah. In this baby, the recent case, is actually only have 1 mutation.
Okay.
Only in 677T heterozygote, but the parents, the mother has 2 different mutations.
Okay. All right. Okay. In Yarsi's hospital, we're going to have collaboration with Rumah Sakit Yarsi to offer this genetic testing, especially for the mothers. Any questions from students, clinicians here? Oh yes, please. Please attend.
It's more a comment than a question. I really enjoyed your talk. I learned something new today about how even with the genetic abnormalities, high dose folic acid can help reverse the effects of the gene defect. Is this? It sounds like the case that you reported or that you presented is rare or new. Is this something that you reported in the literature yet?
Not yet.
Yeah.
Yeah, I should collect all of our cases, because actually we use folic acids not only for the neural tube defect history, but also for recurrent pregnancy loss. So we assume when they have a recurrent pregnancy loss, maybe the baby get less of blood from the mother, and folic acid deficiency or methyltetrahydrofolate mutation can make the vessel, the blood vessel in the uterine sclerosis. So that's why the baby get IUGR or recurrent pregnancy loss. Yeah, can be IUGR, so baby born small, Yeah. And we have experience for this because I'm helping actually the IVF team, and we give the folic acid high dose, and they have good product, especially for the RBL. It's very clear, and after that they can have a normal, normal baby.
Wow, it's fascinating.
Yeah.
Thank you very much, Professor. I learned so much. Thank you.
Thank you. I would like to give a follow-up question, Prof, because from Dr. Ochal about the environment. Because besides genetics, we also have epigenetics, Prof. So any recent studies about the contribution of epigenetics alteration leading to this neural tube defect?
I don't have this study, but I already mentioned that the environmental factor may be influence also to the folic acid deficiency,
Right.
or other birth defect, not just folic acid deficiency.
Right, because in our university we do have a machine that can we call next-gen sequencing to look at the epigenetic alteration. So we looked at the stunting.
Methylation, I think we can see.
We can?
Yeah,
Okay.
I already mentioned that there is can be methylation, so the gene is not working well because
Right.
of the methylation.
Yeah, so there will be another venues for research that we can explore the involvement of epigenetics.
Yeah.
Any other questions? If there's no question, Prof is going to give you a question to test your knowledge, so nobody can leave until you can answer Prof's question. Any other question?
Student, please.
Students? Oh, Prof.
Prof. Prof, ya.
Prof. Sultana, from cellular point of view, how far we can detect, predict, and then follow up patient?
Detect, predict, and follow up.
Takes a long time.
Yeah, we only do molecular analysis. Yeah, even we do only one gene, only methyl tetrahydrofolate (MTHFR). But there are so many genes already. 191 gene used for the screening. Yeah, panel gene using NGS. So we couldn't identify the cell itself, but if we do maybe blood smear, we can see that there is possibility the patient with anemia perniciosa. So we will found the megaloblast, so the big of red blood cell, and also in neutrophil we can find a lot of the neutrophil with a lot of the nucleus, cabang-cabang, yeah, like branch or processes, yeah. So the in neutrophil usually only like only one or two, but it can be more in the anemia perniciosa. So I think I don't know, Dr. Okra agree or not. I think for all cases with NTD, we should also collect the blood from the mother, a blood smear, and we evaluate the cell. Yeah, because if actually the mother has anemia perniciosa, so maybe we have to treat the mother also. And if the mother actually has the mutation, especially for homozygote mutation, we maybe have to treat folic acid for whole life, I think. Yeah, for whole life. Yeah, but for your question, actually I cannot answer clearly.
Okay. Postnatally, how can we empower the village midwife to detect this, and then what can she suggest or refer as a follow-up?
Yes, I think mostly for Spina bifida occulta cannot be identified maybe by the midwife. So I think we have to educate them. Yeah, if we found something like on the back, something with a lot of hair and in circle, this is must be spina bifida and have to be consulted to the doctor. But if spina bifida cystica is very clear, I think the midwife will send to the hospital to the specialist for the further management. Yeah.
Prof. Sultan, I have a question for you because I know one of your expertise is intellectual disabilities. Have you seen in your practice some adult who have actually history of spina bifida when they're a childhood, and is it really they have this some issue with their cognition?
I haven't seen, but I saw patient with a disorder of sex development and spina bifida. I don't know in America, Dr. Okta? Do you have a spina bifida with other syndrome? He asked me about this intellectual disability patient with spina bifida, and I couldn't find up to now, but I found one patient with a disorder of sex development and also spina bifida. Because you mentioned about hypospadia things.
No, I think, you know.
Oh, not hypospadia, heterocephalus.
Hydrocephalus, yes,
Yes.
but it's known association. But in terms of like, you know, any other genetic abnormality that comes with spina bifida, I think it's very rare. But we know that some patients with spina bifida have other issues, such as like, you know, we have a patient with trisomy 13, you know, it didn't survive. And then we have another patient with like a very rare genetic disorder, which, you know, Becker syndrome, I believe. So we see very, you know, low numbers of patients with other genetic abnormalities. But as you said, Professor, you know, it is not known if they're directly correlated with spina bifida or it was just a coincidence that the spina bifida occurred in this patient with other genetic abnormality. I have one baby who had an in utero closure, and for in utero closure, they look at, you know, amniocentesis. Even in that, they couldn't catch this genetic abnormality, which was very rare, apparently, and very minimal. So they did in utero closure, but the baby turned out to have other disabilities. I mean, I think it's difficult to say if it's directly related to spina bifida or it's a syndrome. But I don't have any other patients.
And just to add to your question, I don't know if this will help, but so the patients who have the spina bifida and the associated cerebral malformations, they're known to have cognitive disabilities or impaired executive functioning. That's well established. Despite, let's say, even if they're treated with hydrocephalus, with a VP shunt, they still have those abnormalities because of those existing brain malformations.
Yeah.
And now we're looking at spina bifida and the rate of autism spectrum disorders in spina bifida, but I'm not sure if it's a genetic abnormality that's added to it or it's just, again, a function of cognitive function, because we don't know the genetics of, you know, autism as much. But we see the same things. It's difficult task. May I have one question?
Oh, yes, okay.
So do you have like I'm sure you do have like national newborn screening, right?
Just start.
You just started.
Start this year, not now, later maybe, or maybe next year. But already been approved by our Ministry of Health for the newborn screening. Before that, we only have newborn screening for hypothyroidism.
Yes.
But next will be hypothyroidism, congenital adrenal hyperplasia, and also G6PD deficiency. Yeah. But maybe next year will be start.
And is there any I know that they do it in Turkey, we don't do it in the United States, but the couples before they get married, they have like certain blood tests that they do for such as muscular dystrophy, SMA gene is now very popular, that they look at the couple before they even get pregnant or get actually married. So there's like mandatory tests that the government does in Turkey for couples that are getting married. Is there anything like that in Indonesia?
No. we don't have.
But maybe for thalassemia, no? Oh, it's not mandatory.
If already been known that the family with thalassemia, then, but not government policy.
Yeah.
Yeah, just between doctor and patient only. Yeah.
In fact. I don't know if it's a good program or not, but I guess they were able to catch some of the spina muscular dystrophy families before. But what do you say? You just tell them not to get married? I don't know, but it's interesting.
Yeah.
The Duchenne muscular dystrophy, is it very common in Indonesia?
Yeah, it's quite common too. We invite actually one patient. We'll see her.
Oh, okay.
Yeah,
Right.
doctor. We invite one patient with Duchenne muscular dystrophy now. Yeah, he's here, and we have two affected in the family, and we did already the OS. We found also Kleefstra syndrome, so double abnormality. Yeah, I will show you.
Looks like there'll be lots of interesting collaboration after this.
We have a lot.
Right. Yeah. Indonesia is 200 million people, so we'll find eventually. Okay. All right. Please give a round of applause for Prof. Sultana. Thank you so much. It's been a long, productive talks with lots of engagement. We really appreciate. So I guess this time about to lunch, right? Yeah. Okay. So I'll give it back to you. Thank you.
Thank you very much for all the speakers and the moderator for the first session. As a token of our appreciation, we'd like to invite our guest speakers and moderator to receive a souvenir, and the souvenir will be delivered by Professor Dr. Fazli Jalal, PhD, as a rector of YRC University, and also Dr. Astri. Thank you very much once again for all of the speakers and also our moderator for the first session. Our next agenda is the second session of today's seminars. There will be two speakers for the second session. The first one is Dr. Elsha Sufrianti, and the last session will be Dr. Asfianti. The session will be led by Dr. Farah Kurau, but before that, let me introduce our moderator from her curriculum vitae. So this is a CV of Dr. Farah Kurau. Right now, she is a forensic doctor at Bayangkara Tingkat 1 Pusdokes Polri Hospital and YRC Hospital, and she is also a lecturer at YRC University, and there's all of her educational background and achievements. I kindly invite the moderator to the front. Please start the second session. Thank you very much, Doctor.
Thank you so much, Dr. Amel. Good afternoon, everyone. Okay, can I see your enthusiasm for the second session? Okay, can we have a warm applause for all the speakers? Okay. So to light up the atmosphere, I would like to start with a pantun. I don't know what pantun is in English, but I think it's a 4-line verse, like in English. So in this gathering, we found our grace, studying Spina Bifida with open hearts and smiling face. Let's explore, discover, and embrace, and make today's seminar a special place. Thank you. So my name is Farah, and it is a great honor for me to be your second moderator for this second session. Well, I'm a forensic pathologist, actually. It is very different field of study at my daily activities. But I once performed an autopsy with a baby with spina bifida. It is being murdered by her own mother, actually. So yeah. So without further ado, we will have our first speaker in this second session. It is Dr. Elsha, and we have also Dr. Astri. Both of them are lecturers here in YRC Medicine faculty, and both of them also served in YRC Hospital. So the first speaker, I would like to invite Dr. Elsha to the stage. She will be presenting about pediatrician's comprehensive approach in spina bifida. So Dr. Elsha, she trained her pediatrician at University Indonesia and graduated in 2007. And then she continued her doctoral in medical health and education in Universitas Gadjah Mada. She is currently a lecturer here in YRC Medicine faculty and also a pediatrician in YRC Hospital. Dr. Elsha, you can join us upstage. You have 15 minutes. Whenever you're ready, the stage is all yours.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Farah. Allow me to continue the presentation. This is a pediatrician comprehensive approach in spina bifida. Okay, spina bifida is a congenital neural tube defect where the spine and spinal cord don't form properly. It's one of the most common entities in pediatrics, cause of childhood lifelong disabilities, medical and special education costs, emotional and financial drain for the families. Occurs early in fetal development, often within the first 28 days of pregnancy. And when we give folic acid supplementation in the periconceptional period of woman has reduced the incidence of NTDs by 70%. This is the types of spina bifida. And number 1 is spina bifida occulta. This is the mildest and most common form, often asymptomatic, may be found incidentally, may have a thread of hair, dimple, or birthmark on the lower back. And then the second is meningocele. Meningons protrude through a spinal opening, form a fluid-filled sac. Spinal cord remain in place. This is the less common and may cause fewer neurologic problem. And this the spina bifida aperta, meningocele, most severe form, cause significant neurological impairment like paralysis and incontinence, often associated with SIRI2 malformation and hydrocephalus. This is the severest one, myeloschisis or rachischisis. This is the nerve tissue is here fully bare and dermal or meningeal covering is absent. The closure of the neural fold fails to occur. And then we can diagnose spina bifida with prenatal diagnosis with serum alpha fetoprotein of the mother, ultrasound or amniocentesis. And then postnatal diagnosis, we can go to physical examination in children and imaging MRI or CT to assess spinal and brain involvement. The clinical features may be vary by the type and severity, include motor deficit, weakness or paralysis of lower limbs, sensory loss, neurologic bladder or bowel dysfunction, hydrocephalus, orthopedic issue like clubfoot, hip dislocation and scoliosis, cognitive impairment, especially patient with hydrocephalus. The management include prenatal intervention, postnatal surgery, and multidisciplinary care, and this is the point of pediatric view. Comprehensive approach in pediatric in spina bifida. Pediatrics acts as the central coordinator in a multidisciplinary care models that integrated medical, developmental, psychosocial, and educational intervention to support the children with spina bifida from infancy through young adulthood. And this is a pediatrician lead synchronized involving specialists in urology, neurology, orthopedics, rehabilitation, psychology, and education to ensure holistic and continuous support to patients with spina bifida. Holistic and Family Care Center help by addressing cognitive and behavioral development, mental health and emotional well-being, school performance and adaptive functioning, and family education and empowerment. And then pediatrician deliver appropriate care when infancy to preschool. We monitor growth and neurodevelopment of the patient. When the school age, we support academic integration and self-care skill. And when the patient in adolescent, foster autonomy, sexual health education, and transition planning. And this transition to adult care, a key role of pediatrician to prepare youth for transition to adult health services by promoting medical self-assessment, identify formation and health-related decision-making. And the last, educator, pediatrician serve as educator for family, for school or system, advocating by policies and resources for children with spina bifida. And this is the journal about spina bifida. This journal about multidisciplinary problem This study aimed to analyze publication with diagnosis and treatment result of patients with neurological, orthopedic, neurological, ophthalmological problem with spina bifida. And this journal concludes that multidiscipline team of specialists comprising neurologists, neurosurgeon, urologist, orthopedic surgeon, ophthalmologist, psychologist should be involved in treating the children with the above presented problem. The use of integrated approach to treat this group is absolutely justified and enable to maximum rehabilitation potential of the child to be achieved. And this is the literature about growth in patients with spina bifida, height and body mass index distribution in children and adolescents with and without spina bifida. In this research, they conclude that these findings suggest in Brazilian children and adolescents with spina bifida may be at risk for reduced height and increased body mass index. And it is the last about the developmental patient with spina bifida. The research about growth of condition-related knowledge among youth with spina bifida associated with neurocognitive functioning and self-management skills. They conclude that focus on early education about spina bifida, support by cognitive training and family involvement. Cognitive support intervention like memory or in attention training may help both early understanding. Prognosis patient with spina bifida depends on the level and severity of the lesion. With early intervention and ongoing care, many children can lead fulfilling life. Chronic issues may include mobility challenges, learning disability, and bladder or bowel dysfunction. And the last, the take-home message, spina bifida presents complex, lifelong challenges across multiple domains. Pediatricians play a role in navigating integrated cross-section care. Empowering families and supporting independence are essential for lifelong outcome. Planned transition leads to better health, psychosocial, and functional outcome in adulthood. Thank you.
Thank you, Dr. Elsha, for the presentation. That was very short but very inspiring us, and we gain new information from Dr. Elsha. We will now continue to our second speaker before we go to the Q&A session. For the second speaker is Dr. Astri. We will invite her to join us to the stage. Dr. Astri is a neurosurgeon practicing in YRC Hospital. She is also a lecturer here in YRC Medicine faculty. She is the head of Department of Neurosurgery in YRC Hospital, and she has been continuing fellowship from all over the countries, I guess, to always approaching the neurosurgeon field. To Dr. Astri, you have 15 minutes maximum to presentation.
15 minutes.
Yes. Whenever you're ready, the stage is all yours.
Okay, thank you. Thank you, Dr. Farah. Good afternoon, everyone. This is the last session, and I will present the effort of YRC Hospital in developing an integrated and comprehensive approach to managing spina bifida, a condition that requires multidisciplinary and continuous care. Dr. Apara, the type, yes, okay, the presentation. This is the diet. Okay. This is our hospital. Yeah, we invited. Yeah, this is our hospital, YRC Hospital, next to the university. Yeah, the previous lecture always said the definition about the spina bifida. The spina bifida is neurotube defect, and then complex condition requiring lifelong multidisciplinary care. ERC Hospital is committed to establishing a comprehensive and integrated spina bifida care program, and we are working on progress with multidisciplinary like a genomic, and then also our other specialties, not only the pediatric neurosurgeon, but also the pediatrician, neurologist, and orthopedics. Why we needed integrated care methods? Because if we want to the good outcomes, fragmented care leads to poor outcomes and caregiver burden. Integrated support need for early intervention and holistic support. So the goals of the program, our goals include early in diagnosis and prenatal counseling, and then also the coordinated multidisciplinary treatment, and then the family-centered education and support, and the last, improve quality of life and functional independence. Multidisciplinary team that we already built consists of many specialties. In neurosurgery field, we treat the spina bifida without hydrocephalus and also the myelomeningocele closure. For the pediatric and neonatology, they do the early stabilization, nutrition, infection, and then our urologists, they treat the neurogenic bladder management. For the orthopedic, they also make some treatment for the lower limb deformities and also the mobility, and also the PT, physiotherapy, and then the rehab. They also make some parallel treatment between the surgery or between choose our surgery. Radiology is also our friend, because we need, we prevent the more exposure, the radiation exposure. So we did much USG and something like that, or MRI, and the anesthesiologists, we work together, because this several patient, we have to do the emergency surgery early in after the birth, and the last we did before 24 hours. Obstetricians is also several times sending to the neurosurgeon several cases, but the specialties cases, they already have a good prenatal care and come from the good social economy, but still have a spina bifida cases. This is the new collaboration with the economic counseling with Professor Sutana. We already built in like almost 1 year. Clinical psychology and social worker, and also the nursing and care coordinator. Maybe I already talked about the care of nursing, like how to treat the wound. Yeah, this is like a simple, but if we don't treat with maximally, it can cause infection, maybe severe infection, and it will cause the not good condition for the patient, and we must redo the surgery. So if we can make it in the one chart, the first step may be the prenatal, or we have the referral prenatal from the obstetrician or midwife and do some diagnosis. After that, we arrange to birth planning at the ERC hospital. After birth, neonatal surgical intervention, we arrange for that. and then post-operative monitoring, rehabilitation, and long-term monitoring. We did parallelly with the genomic counseling, and we also observe the patient until the adolescent or adult care. And this is the last, we talk about registry. Maybe we are going to have some project, maybe Professor Fasli? Yeah. We will try to make it next, coming soon, for the registry in spina bifida, at least in Jakarta. This is some picture that we did in YRC Hospital. I remember I did it in 2021 when we are in the pandemic area. Yeah, we did it with intraoperative monitoring, and now the patient already entered the I think elementary school. Yeah. Facilities and support service. This is the important thing, I think, because we have to have a dedicated pediatric nursery and also the NICU and also the pediatrician. I very blessing because I have a great team with the pediatrician, Dr. Elsa, and the team, and also the anesthesiologist and also the rehab. Yeah, and the support of the service is also imaging and diagnostic. Yeah, this is not easy because if you want to get the MRI imaging, yeah, it's such an effort. In our hospital, we don't have MRI, so I have to transfer to another hospital, and then if we have a patient maybe after 3 months old, yeah, it's not easy because I have to call my anesthetic, yeah, to do the sedation or like anesthesia. And the next is child development and family counseling unit. Also patient navigation and case management is also the service that we need more. This is our pediatric intensive care unit. I and Dr. Elsa, there is a room, yeah. This is the patient. We usually put some balloons, so the patient don't realize that they are in a hospital. They are always happy, yeah. And then they can see the video, yeah, on YouTube. And this is the modern dressing that I used to do in my surgery, the less traumatic for the patient, and I put a sticker like that. This is the last that I did, that we have a melamine cell, and then yeah, I put the modern dressing. So the education and community is also important, which the parent and caregiver workshop is needed more and more, and then collaboration with local OBGYN and midwives, I think, not also OBGYN and midwives, I think also with the pediatrician, because we already make it in 3 years, Dr. Elsa, right? In 3 years, we do some collaboration with the pediatric surrounding this YRC hospital. Collaboration and networking. This is a partnership with national and international spina bifida networks. Yeah, so that's why we are here. Yeah, and then training programs with external experts. I hope that we can make it. And then referral and knowledge exchange platform. Yeah, the pilot phase result, I hope that we can have the number of patients of enroll and then type of intervention period, preliminary functional outcome, and also parental certification metrics. Conclusion, yeah, that we need integrated care from the treatment of spina bifida to improve long-term outcomes, and YARSI is poised to become a center of excellence in spina bifida care. The collaboration and commitment are key to success. I think it's finished. Thank you.
Okay, thank you. Thank you, Dr. Astri. You can join us here on the couch. Yeah. We will move to the question and answer session. If someone have any question for our two speakers, you can just raise your hand. Oh, okay. Go.
Have a comment, and I'm so happy to see, Astrid, that you have professor in your team. In my hospital, we believe in multidisciplinary care of spina bifida because that's where you get the outcomes better, right? So, and my director is a pediatrician in the clinic who is also a rehabilitation doctor. So she's a pediatrician and a rehabilitation doctor. That is our boss. So I believe that neurosurgeons are just a little part of the team, but the main thing falls onto the pediatricians or rehabilitation team to oversee the entire patient, where we look at a small, part of it. So I'm so happy to see that you have a great collaborator with your pediatrician. Yeah. Congratulations.
Thank you, Doctor. Yes, I think their presentation really highlights what YARSI Hospital can do for a spina bifida patient. And it is true that a neurosurgeon maybe just play a little role in that, because the first role, I think it goes to the obstetrician and the pediatricians to detect more early detection for the patients. So I think we have no questions yet. Yes, genetic counseling is also plays a great role in these spina bifida patients. And then I would like to ask Dr. Elisha, if some patients, children, have to undergo surgery, is there any requirements for the patients? I mean, like laboratory results, or maybe a specific age, or maybe specific weight or body mass index?
No, if this is the sorry, I answer in bahasa. Operasi spina bifida memerlukan persiapan seperti operasi lainnya, kecuali pada kondisi yang akut. Kita pernah menemukan dengan Dr. Astri satu pasien baru lahir, tidak terdeteksi, kemudian lahir dan spina bifidanya ruptur. Jadi baru lahir diketahui. Nah, pada saat itu langsung Dr. Astri ambil alih, masuk operasi yang langsung dijahit, ditutup, dan kebetulan pasien itu meninggal pada usia 1 year, pass away in 1 year. Jadi sudah meninggal, dan memang pasien itu dengan hidrosefalus. Jadi untuk persiapan operasi, kalau misalnya operasinya elektif masih bisa kita seperti persiapan operasi lainnya, tapi kalau dalam kondisi gawat darurat, emergency case, kita langsung OT dengan persiapan maksimal yang bisa kita lakukan.
Okay, so Dr. Astri, would you like to add to that question? Is there any special requirements for the baby before undergoing surgery?
Yeah, it's similar like Dr. also answered, but yeah, actually, usually we know the rule of 10. Maybe yes. the pediatrician and then anesthetic, the rule of 10 is important. But if we have emergency situation like a rupture and then progressively rupture, and I have it once, so I choose to do it in emergency surgery without considering anything. And luckily our anesthesiology is, yeah, very good and very brave.
Okay.
So I did it.
Okay, so because regardless if this is an elective surgery, so we can still go by the rule of 10. So hemoglobin of 10 grams per deciliter, and then 10 pounds, and then leukocyte under 10,000, yeah, something like that. But if the baby undergoes some emergency condition, then we have to rule out that and then undergo surgery in as fast as we can. So if there is anything experiences, Prof or Doctor, about to share your experience when undergoing surgery.
Yeah, so for the elective surgical cases, we prefer to wait until they're 3 months old. That way they're able to produce their own red cells and white cells on their own. But if you have to do it emergently, then of course that's what you do. I did have one comment about the multidisciplinary care. What we found often is the care that the patients need a lot are not medical. They need social care, or they need support in school, and they also just need just education. So it's very important to have that built into your clinic. The other thing is once mothers hear that you have a multidisciplinary spina bifida care clinic, they will come to your clinic even if their children are old already. So you have to be prepared for the older patients with spina bifida because they have different needs, as you pointed out, in adolescence. And one of that is also planning for transition of care outside of the spina bifida clinic. So this is the right way to do it, and I applaud you for putting this together. I'm not sure, are there other comprehensive spina bifida care clinics in your city?
Not yet, and
yeah.
I'll make it.
Yeah, yeah. So yeah, it was very important work that you're doing. Congratulations.
Okay, we give a warm applause, Dr. Asri, Dr. Elsha. So, is there anyone here in the auditorium who would like to ask a question or maybe to add a comment to Dr. Elsha, Dr. Astri? Or Dr. Astri, do you have any comments to your program? I mean, this is a very, I know this is a new program in ERC Hospital. You have just experienced 1 year on this program.
Nearly
2 years.
2 years.
Your program. Okay, so this is a very interesting way. So we have to give them a warm and loud applause to Dr. Astri and Dr. Elsha. So my next question, I would like to ask to Dr. Astri. I know you are very active in your organization in Indonesian Association of Neurosurgeons. Are there any specific programs or maybe some that you and your organization do for these spina bifida cases?
For generic?
Yes.
I just started with Professor Sultana. I have to learn a lot from Professor. Yeah, just started.
Just started this counseling program.
Yeah.
Okay. I mean, in Indonesia before we don't start this program
Maybe
yet.
It's like an individually case, between the patient and then the nurse surgeon, or and maybe with the pediatrician, just it, but no conclusion, no observation, just individually case. But we will make it in a
in several years
several years or several cases about it.
Okay, yes. Because I know spina bifida is a very challenging disease. It is not something that we can correctly treatment for the patients just by one appointment, I think it's very continuing program for the patients also. So I'd like to express my gratitude for Dr. Ase and Dr. Elsha for what they have done here in ERC Hospital for all the Spina Bifida patients. We just pray for you to be healthy and to be more successful in this program, and you can be more useful for the patients in Indonesia also. Okay, so I think, ladies and gentlemen, we have reached our final session in this second session. So I would like to close again with pantun. The bird sings, the river flows, the sun is high and the sky is so wide. How much we learn, nobody knows. Thanks for joining this learning ride. Thank you so much for your attention. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much for all of the speakers and also our moderator. As a token of our appreciation, we'd like to invite our speakers and moderator to receive souvenirs. And the souvenirs will be delivered by Professor Dr. Pratiwi Puji Lestari, PhD, as a Dean of YRC University. For all of the speaker and moderator, please come to the front. So here's a photo session of all of the speakers, moderators for today's special agenda. Thank you very much for all of the professor and doctors and also all of the participants of today's seminar, a comprehensive overview of Spina Bifida. Now that we already finished the whole agenda for today, it's time for us to close this conference. By reciting Hamdalah together, let's close this event. Alhamdulillahirabbil alamin. On behalf of the committee, we would like to say thank you very much for attending this conference. We hope you enjoy this conference as much as we do. Wassalamualaikum warahmatullahi wabarakatuh.